they were talking about.
Magic. Hi, I'm Fred Penzel. I'm a psychologist. I work at a place called Western Suffolk Psychological Services in Huntington, Long Island, New York. I've been treating trich and related disorders for, this is my 24th year, since the dark ages. And this is a talk I really like to do because it really gets me to say just about everything I have to say on this subject. And I like quotes very much, by the way. So an expert is a man who's made all mistakes which can be made in a very narrow field. That was by Niels Bohr, who was a very famous physicist and one of the fathers of the atomic bomb. So, and then one further, I like quotes. If you ever go to my website, by the way, you'll see a big collection of quotes there. Mark Twain is the source of some of the best quotes ever, really. It's noble to teach oneself, it's still nobler to teach others, and less trouble. So, the next bunch of slides I'm going to breeze through here because they usually, when I give talks to people who don't know a lot about BFRBs, and by that I mean, skin picking, hair pulling, nail biting, the body-focused repetitive behaviors. I like to show them pictures of what it looks like, especially practitioners and all. So I'm just going to breeze through these pretty quickly. These are some somewhat extreme pictures of what skin picking and hair pulling and nail biting can look like. So this is just sort of for your layperson who, or your uninformed practitioner, which there's quite a few, unfortunately. We like to show them what it looks like. Okay, and one further quote, which is also one of my favorites, which is, you cannot prevent the birds of sorrow from flying over your head, you can't prevent them from building nests in your hair. So, in fact, I think I gave that to you in your packet because, is that in the packet? Yeah, I really like that quote a lot. Let me just say that there's a lot of, as I'm sure you well know, there's a lot of misunderstandings about this disorder. There's a lot of ignorance out there. Things have improved vastly during the time I've been in this field. It's incredible, the changes. But I find that people who sometimes have some of the greatest prejudices still against people with these problems are people who have these problems themselves. And as part of this talk and then part of my writings and the things that I do try to correct for this in people and get them to see the realities of this and to try to think more logically about it. This is sort of how most people, I think, tend to view themselves, or how the uninformed sometimes tend to view this problem as well. So, Trichotillomania, as you probably know by now, and you probably get sick of hearing these criteria, because you've probably been to several talks by now that have gone over them. The basic definition, and by the way, this is from the DSM-IV. I don't necessarily like all these things. Again, it's recurrent pulling out of hair resulting in noticeable loss. But again, sometimes the loss isn't so noticeable. Sometimes people sort of what we call graze and the hair's just thin. So you'd have to look very closely. It's not that noticeable. Secondly, increasing sense of tension before or when attempting to resist. Again, not everybody feels that tension. But the guys who originally created these criteria, that's what they thought it was. So that's what it's stayed ever since. In fact, TLC and the Science Advisory Board of TLC, we've been talking about strategies to get these criteria revised because they're kind of faulty and they let a lot of people slip through the cracks, unfortunately. Pleasure, gratification, or relief when pulling out of the hair. Again, not necessarily so. Some people don't feel anything when they do their hair pulling. And all the things I'm saying about this are true of all the BFRBs, you'll understand. Most of these things are pretty applicable across the board to all these disorders. It's not accounted for by any other disorder. Well, there's not too many other disorders, although sometimes in the developmentally disabled, you will see people pull hair or scratch themselves or do things to their skin. But it's done for probably similar but not quite the same reasons. And that it causes significant distress or impairment in social, occupational, or other important areas of function. That's relative also. So they have scales that can measure it, but anyway, just so you know what the party line is on this stuff. The DSM really exists more for the purposes of the insurance companies, by the way. Because then when you tell them it's a diagnosis, they can sort of understand it and look it up somewhere. It makes it very handy for them. So among us practitioners, we're sort of a little more inclusive in our definitions of what is a BFRB. All the other ones besides hair pulling come under this. Impulse control disorder not otherwise specified. That's skin picking and nail biting fall under this. So nail biting is also known as onychophagia, and skin picking has been referred to as dermatillomania. but officially, according to the DSM, they fall under this, and it says for disorders of impulse control that do not meet the criteria for any specific impulse control disorder. Well, nobody just ever got around to coming up with a better classification system. These shouldn't even be called impulse control disorders, as you'll see in a moment. I just thought I would show you really quickly. This is the gentleman who named Trichotillomania. Most people have never seen his picture, although they may have heard his name. I actually found it on the internet. I did an image search, and he popped up, lo and behold. François-Henri Halipau, who was a French dermatologist, and who did document the case of a young man who pulled out his hair, and this was in the 19th century. So he's the one who gave it his name. And somebody who's even less well known than this gentleman is Louis Braque, who was the one who first diagnosed compulsive skin picking. He named it acne excoriae. Now, impulse control disorders, as you see, Trichotillomania and the NOS group that we're going to be concerned with really have no relationship, basically, to any of these other things. This is for people who can't control their temper and have outbursts of extreme anger. This is, as we know, shoplifters and pathological gamblers, all the guys who go to GA and all who lose their house at the track. Pyromania, again, what compulsive fire setting has to do with pulling out your hair or picking your skin. God only knows these things. Okay, now BFRBs, as we say, the three that I already mentioned, as you can see are on here. Compulsive nose picking, believe it or not, don't laugh. There are people who do it not for the same reasons that other people do it. They do it for sensation, and they do it for the same reason that people pick their skin or pull their hair. Compulsive biting of the inside of the cheek. I've seen some very serious ulcers and damage caused to tissue inside the mouth by people biting the inside of their mouth. And lip biting or lip picking, which I have run across also. So this is very very prevalent. These have not been as well studied, these last three. The first three, of course, are a little bit better studied, but as you can see from what we've been saying about research, we need a lot more support for research. We need a lot more research in general. So, how prevalent are these things, just since we're talking about all of them? Trichotillomania, again, this is a study done in 1994 of a college sample. 1.5% of the males in this study were found to meet criteria for trichotillomania, and 3.6% of females. So that's, when you start adding these up, it's quite a few people we're talking about. This is not so obscure and rare as people like to think it is. Skin picking, this was a study that was just done a few years ago, 4.6% of a non-clinical college sample. In other words, these are just college students. These weren't people who came to a clinic or people who had previously been identified. Nail biting, Ellen Tang found 6.4%. These were all pretty good samples too. 6.4% of a non-clinical college sample, and then mouth, lip, or cheek chewing. She also did a study that's 5.7% of a college sample. So when you take this all together, it adds up to there's quite a few people out there picking, biting, and scratching themselves and pulling out their hair. So this is really, So if you think you're very few in numbers, guess again. There's many, many people out there who are doing it to the levels that they meet criteria for disorder. Okay, physical injuries associated with BFRBs. Now, BFRBs are serious business, as you can see. People get repetitive strain injuries, for instance, like reaching around to pull hairs at the back of the head can cause back and shoulder problems. Tendinitis, people like cocking their wrist to pull. Eye irritations among eyelash pullers particularly. I get a lot of children I see sometimes with like red swollen eyelids. Trichobezoars, this is a little rarer. I get emails about this once in a while. People say, oh, I've been swallowing hair for years, do you think I'm at risk? These are hairballs basically that build up in the digestive tract that can cause intestinal blockages and can be fatal in very extreme circumstances. Luckily, they're not that common, but when they do occur, they have to generally be removed surgically. People can't clear these things themselves. If you have long hairs and you swallow lots of them, this can happen. It can be determined by X-ray, obviously. They can spot them, but that's probably one of the more serious side effects of hair pulling. Onychophagia problems. These are sort of secondary problems just because people won't go to doctors for exams that they need for eye exams or GYN type exams because they're too embarrassed. The doctor's going to say, what happened to your hair? What's going on? And of course, people don't want to say, and they don't want to be examined closely, so they just don't go. Basically, I always ask my patients, in fact, if they have been going for these things recently, and I will send them to friendly doctors that I know if they have not, because I think it's very important. Skin infections. I had a patient, skin picker, who developed an infection of a staph type of bacteria known as flesh-eating bacteria. You probably heard of them. She had to get surgery, actually, to have that corrected, and her physician told her if she waited a couple of more days, she might have lost her leg. So that's how serious that can get. And, of course, scarring of the skin. I'm seeing a lovely young dancer right now whose face is just like a mass of scars currently because of years of picking and squeezing and scratching and scraping at her skin. I'm figuring when we get her better, I may send her for some kind of either surgical treatment or dermabrasion or whatever, you know, a plastic surgeon will determine is best for her. Okay, now these things also occur in animals. It's important to understand the animal background. There's a lot of animal people at this meeting, luckily. There's been a few in the past, but I've never seen so many animal scientists here, and I think this is good because it can shed a lot of light, as they've been saying. In dogs, we have canine acrolick. This is where larger breeds of dogs pick and lick the skin off their forepaws. Sometimes they'll expose the tendons, and sometimes the damage is so bad the dog will have to be put down. Yeah?
I actually got the dog that does that.
Yeah, is it one of the larger dogs, like a lab or something?
125 pounds.
There you go.
It's called Trichotillomania, and there's no cure for it.
Sometimes, actually, they have given them antidepressants. I've heard of dogs being treated with Prozac and similar things. So it actually, you know, works on them. They're mammals. You know, they got brains, so they got brain chemistry not exactly like ours, but it's similar enough that antidepressant medication has been used by vets on them.
Antibiotics sometimes will slow it down.
It may relieve the damage of speed healing, but it won't get to the root of the problem, basically, because we believe these are all, as you'll see, these are all neurobiological problems. Cats have what it's referred to as psychogenic alopecia, but the cats are pulling out their fur. Horses, there's a whole bunch of things that come under the heading of what's called equine self-mutilation syndrome. My son rides horses, so I'm always around stables talking to horse people, so I've learned quite a bit. There's something called cribbing, which is very bizarre behavior, where horses bite the edges of their stalls and suck in a lot of air and then belch it back up. It's like a self-stimulating kind of thing. Cribbing, this is where, I'm trying to remember, that was cribbing, sorry. Flank biting, that sounds pretty obvious. They bite their flanks and pull the hair. Often weaving, this is where horses sort of rock back and forth on their feet from side to side repetitively. And stall walking, they'll just keep walking in circles repetitively in their stall. And we believe that these are all, you know, kind of similar things done for similar reasons, which I'll show you. But animals, you know, should not be ignored. What they do is very informative. So, anyway, just thought I'd throw that in. Now, let me teach you about a subject which is a theory, mind you, but it's my explanation for this, and it's how I approach this disorder and the basis on which I treat people. And a lot of people are sort of coming around to sort of agreeing with this also, which I call the stimulus regulation model of BFRBs. And there's an article on my website, which when we're all done today, I'll give you the web address, unless I put it in the packet somewhere there. What it is I believe that behaviors such as hair pulling, skin picking, nail biting, etc. may be an external attempt on the part of genetically prone individuals to regulate an internal state of stimulatory imbalance. In other words, people are trying to regulate levels of stimulation within their nervous systems. Now, there's a concept that's called homeostasis. And homeostasis is the body's way of maintaining normal internal stability. You have a whole bunch of things that come under the heading of homeostasis. I say it does this by coordinating the responses of internal systems that automatically compensate for environmental changes. Well, what does that mean? In other words, it's how your body regulates things like blood pressure, temperature, respiration, heart rate. All the basic processes that keep you alive and keep you going have to be maintained within a certain zone, because if it gets above or below that zone, damage or even death can occur. So this is your body's thermostat system, basically. It keeps things from getting too high or too low. Well, I believe that in BFRBs that something has gone wrong with one aspect of this homeostatic mechanism in the body, and probably exists within the brain. And pulling, picking, biting are all attempts to, from an external level, regulate these internal states, basically. And I'll make that a little clearer as we go on. Now, the nervous system is divided into roughly two halves. I don't know if you remember this from like college biology classes, if you took one of those classes. I don't remember much from college at all, actually. At least not enough to hamper me anyway. But it's divided into two halves. One is the let me start with the parasympathetic. It says it maintains normal operations of the internal organs promotes calm and slow breathing and heart rate, low blood pressure, and maintenance of the digestive system. So this is sort of, keeps things running at normal operational levels the way they should be on a day-to-day, moment-to-moment basis. The sympathetic nervous system, this works counter to the parasympathetic nervous system. It activates fight-or-flight reaction of the internal organs by increasing heart rate, raising blood pressure, dilating the pupils of the eyes, slowing of the digestive tract, releasing glucose from the liver, and decreasing production of saliva and tears. Actually, when my plane landed me late on Thursday night, and I had 10 minutes to run from one gate to a very distant gate at Dallas-Fort Worth Airport, this part of my nervous system kicked in as I got into a dead run trying to get there before they closed the gate, and I missed the last flight to LA. So basically, this part of your nervous system, the way I tell people, this is sort of like the brakes, and this is the gas pedal, basically. This is what releases adrenaline, really gets you pumped up, gets you ready to fight, run away, do whatever you have to do. And the other part, of course, when I got to my seat on the plane, caught my breath and realized I wasn't going to get to LA after all, parasympathetic system kicked in and kind of calmed me down, and I was able to sit there in my seat and read my book and stop perspiring heavily. So a little diagram I like to use to describe how all this works is that I say, pulling is a way of regulating stimulation. There are the two poles here are understimulation and overstimulation. And as many of you know, people don't just pull, kick, or bite when they're stressed. People initially seem to think this is a stress reaction. What they know, because people also do it when they're bored, when they're doing nothing, when they're watching a show on TV they don't care about, or they have to wait a long time for a taxi to show up, or they're reading something boring, or they're sitting in a class and they really hate the subject and would rather be anywhere else at that. So when a person is understimulated, pulling, picking, biting provides stimulation that relieves boredom and inactivity up to one end. Sort of like you're on a tightrope, kind of balancing yourself to try to stay level. On the other side, overstimulation, that pulling, picking, and biting reduces stimulation of stress and excitement. So again, you're trying to keep yourself within a zone, basically, and it sort of works, but unfortunately, as we know, there's side effects. If you could do these things and there was no physical damage or physical consequences, it wouldn't be a problem. But unfortunately, it is a problem. So let's move right along here. So if we're talking about stimulation, the question is, where can stimulation be found? And the answer is where the nerve endings are. Okay, I love this picture. I was so lucky to find that. Now, the kind of stimulation that people get through these behaviors, and I'll describe this a little bit better as we go along too. People, by doing these behaviors, it reduces stimulation, and the way it does that is you focus so much on what you're doing that it sort of puts you into almost people describe it as like a tranced out kind of state, or a completely focused state where you're just doing your behavior and you're not thinking about anything else, and that sort of quiets and calms your whole system, just as if you were doing any kind of relaxing activity like reading a book or meditating, basically. Whereas when you're understimulated, it directly gives that shot of adrenaline almost to your nervous system. It gives you that stimulation that you're lacking at the time. So now the types of stimulation that people go after falls into three most obvious categories: tactile, visual, and oral stimulation, although people don't always think of these things, which I'll explain to you. Tactile stimulation and body-focused behaviors, you can get them from touching or stroking hair, scratching skin, or running your fingers across nails, okay? Tugging at hair, some people just can do that sometimes. Pulling out hair, squeezing, biting, or chewing skin or nails. Handling and manipulating pulled hairs or pieces of nail skin. People don't just pull stuff, they play with it too. They look at it, they roll them between their fingers, they play with them, they pull them apart. People who like to pull the bulbs off of the hairs they pull out, that's another kind of tactile stimulation, pulling the hair between your fingers. Separating the hair bulb from the hair shaft, playing with a separated hair bulb with your fingers, stroking pulled hairs across the cheeks or lips. So these are all ways that you stimulate those tactile nerves at the surface of the skin. And a lot of them, as you can see, do involve the mouth. And the mouth is tremendously represented in the brain among sensory areas. Tremendous amount of nerve endings in that area, as you can imagine. Sources of visual stimulation, watching as a hair is being pulled, either directly or in a mirror. I have a lot of people who like to do that. looking at skin as it is being squeezed or picked, examining hair that has already been pulled. Again, this is coming through the optic nerves now. Examining the hair bulb, either on the hair or once it has been separated from the hair. People, look at these things in a very fascinated kind of a way. In fact, usually I surprise my new patients because they don't expect this question. I mean, I usually know that they're having like pulling problems when they come in, but I say to them, well, what do you do with the hairs after you pull them? And they sort of like give a little start and they say, well, how did he know that I do that? It's like, was there secret somehow? But it's very, very, I tell them, it's very common. A great percentage of people, some people just discard them, but quite a few people play with these things because they have other value beyond pulling. Let's see, examining nails or cuticles is another form. Examining bitten off pieces of nails or cuticles and examining blemishes. So these are all ways that people get visual stimulation from this stuff. Sources of oral stimulation, chewing pulled hairs, big one, biting and chewing nails or cuticles, biting pulled hairs, pulling hairs between the teeth. I had a guy who did this so regularly and so often that he cut grooves in his front teeth, and his dentist was going wild trying to figure out, how is this damage occurring? He said, I've never seen damage in teeth like this before. And of course, the guy wasn't about to tell him, he was just playing. He said, I don't know, just there, I don't know. And the dentist was just, he looked it up in all his dental journals even. He couldn't find any references on it. It was so mysterious. And swallowing hairs, of course, which we mentioned earlier in the trichobezoars. So these are all, so it isn't just about pulling, picking, and biting. It's all the things that come afterward, basically, that we also have to concern ourselves with. It's a little cartoon I got from Carol Novak. I promised her I wouldn't use her cartoons, but I can't help myself. It says, Bonnie's brain is always looking for something for her right hand to do. So, great cartoon. Carol and I both collect cartoons. We often sit down and exchange, so she's probably used some of mine. Okay, why pull or pick to manage stimulation levels? Like, why that and why not anything else? Why not hopping up and down on one foot, or why not, doing anything? I don't know. It says the behavior and hair, skin, or nails are always available. In other words, you can always do them. You've always got a supply. Or if you run out, they'll soon come back again. Areas usually involved in BFRBs can be rich in sensory nerve endings, if you notice. Hair, skin, and nails can be stimulating and interesting to touch. They're very tactile, they have a lot of texture. Even people who don't have these things love to touch their hair and play with their hair. You ever sit behind people at traffic lights and watch girls particularly, playing with their hair or twirling or tugging or, all kinds of things go on. Stopping at traffic lights is a great source of information for me on what people out there in the public are doing with their hair. I've seen people curling their hair with curling irons actually while driving their cars. That's another subject. Grooming behaviors are perhaps already present in the wiring of the brain and can be called up instantly. In other words, these are instinctive behaviors that our ancestors did when they were covered with pelts all over. And of course, lower animals still do, and that's why we also study them to learn what they do. Pulling, picking, and biting appear to be extremely effective in providing or reducing stimulation. They are. They really are. More so than just about any other behaviors. Because you really don't see people do too much else. Which is not, there can be a case made for other addictive kinds of behaviors, and I think they are kind of self-regulation, but they're somewhat different in quality because they tend to be more immediately rewarding even than these kind of behaviors, and they're a little bit more complex in some ways. But again, we have limited time today, so I got to confine myself to this. That could be a whole other talk. BFRBs can be performed either when a person is alone or done discreetly when others are present. So again, you're not limited. Basically, you can do it all over the place. It's available to you. Your brain knows how to do them already. So, okay. So, we're going to talk about so what's the most powerful force in the universe? That is the force of habit, and that is the truth. So, let's talk about body-focused repetitive behaviors. I like to tell people BFRBs are complex problems with many inputs. There are biological inputs, emotional, in other words, your physical condition or physical conditions that you have, or just the biology of regulating yourself. There are emotional inputs. People pull in all kinds of different moods, either to bring on certain mood states or to get rid of certain unpleasant mood or emotional states. Sensory inputs, again, is a very sensory kind of disorders. You're regulating yourself through these different sensory channels. Cognitive, again, certain beliefs or ideas, certain kinds of thinking can lead to pulling can be triggers. These are all potential triggers. All these things. Physical sensation, finding yourself in certain physical situations or physical, can't think of the word, but in other words, certain physical states can lead to pulling and can influence it, and environmental inputs also. People sometimes only pull in certain places at certain times or during certain kinds of events or certain activities. And part of what we try to do, as you'll see later on, is to find out what these are. I'm trying to just lay this all out for you now so that when I talk about the what to do part about these disorders, you'll understand why I recommend the things that I recommend that you do to help yourself. Because it all comes out of this kind of an understanding of this. Otherwise, it doesn't make any sense why you have to do a particular kind of therapy as opposed to any other. Okay. So, in trichotillomania, just to quickly mention here, we're talking about habit and just to give you, this was a study done quite a while ago. Actually, there's newer studies now which may show. I have to really sit down with that data and revise my slides. But the scalp has been seen to be the most popular, followed by eyelashes, eyebrows, pubic hairs, and hairs on the extremities, sort of in descending order of popularity. Why? I suspect the most popular areas are perhaps the ones with the greatest sensory representation in the brain. We have more input areas, basically, for feedback from the nerves that are in these locations. And primary skin picking sites. Pimples and scabs seem to be number one among people who like to pick skin. Red, swollen, or infected spots come in second. This was a study done by Sabina Wilhelm about 7 years ago at Harvard. Healthy skin. This is without even any people will create stuff for themselves if there's nothing particular to pick. Mosquito bites, believe it or not, very popular right up there also, and picking at scars, another area. So just give you an idea. Anyway, the program that I advocate for treating body-focused behaviors, and we can get started on this, although we'll carry this through in the second part of this talk, I call it Habit Reversal Training Plus. Habit reversal training was what I was originally taught back at the very beginning when I first learned how to treat these disorders back in 1982. And at the time, we sort of lumped them all together with obsessive-compulsive disorder. Now we know that this disorder is probably much more of a distant cousin to OCD. But a lot of people think it's OCD and they talk about it that way, but it really isn't, because it has a lot of major differences, which, again, we don't have time to go into today. But in any case, habit reversal is the first part. The second part, which I'll tell you more about, is something called stimulus control. But I believe in the two of them together, actually. And I got to say, though, in all honesty, in the last few years, I've been moving a little bit further away from habit reversal itself and a little more towards stimulus control. But I still do use them both. So I'm going to teach you about both of them. But habit reversal training, as I say, is the best known behavioral treatment and the one we have the most data for. So 3 cheers for HRT. I think I got this in England actually, I think they meant hormone replacement therapy, but you kind of get your pictures where you can. So, anyway, some key references, just think very briefly, why we say this is the one that there's data for. There were 3 major studies that were sort of the foundation for habit reversal training. The first one was a small study done with about a dozen people back in '73 by Dr. Nathan Azarin, a very interesting guy. He not only did the pioneering work in treating these kind of behaviors, but he also pioneered work in toilet training children and also the developmentally disabled and a few other areas too. He's a kind of fascinating guy. He's a real pioneer. Anyway, this was a group of 12 people with all different kinds of behaviors. They didn't really single out any particular one. One of them happened to be an eyelash puller. And I'll be telling you more details about HRT in a little bit. But needless to say, of this group, they found that there was a 90% reduction in habit across all subjects in the 12 individuals who were in this group. Again, a very small study, but considering it was done in 1973, it was astounding because nobody was really looking at these things back then, only Dr. Azarin. Now, Azarin and Nunn, back when they did the original study, viewed these things as nervous habits, they called them, because that was the terminology in those days. They didn't know any better. They felt that these behaviors in most people were usually inhibited by self-consciousness, negative attention from other people, or inconvenience. They were just, pain in the neck to do. They felt that other habits can be personally or socially inconspicuous enough to escape attention. So a lot of things that could be done secretly or done without calling attention to yourself would persist, as opposed to these other types of behaviors which would somehow be suppressed. They also felt that muscles that were involved in the habit as a result of repetition became stronger than the muscles needed to oppose the habit. So that was another bit of their thinking. So this is just to give you a basis to understand what habit reversal is. Let me show you a little bit more about it. So the functions of habit reversal training are to increase awareness of one's own behavior by self-recording. Self-recording is the foundation of this, keeping records of everything you do, basically, as far as your habit goes. To get people to focus on and reduce the tension that precedes calling. This is usually done through relaxation. Again, I'll give you more details on the nuts and bolts of this as we go along. And to learn to perform a muscular movement that is inconspicuous and incompatible with the undesirable behavior. In other words, something you can do with the muscles you need to carry out the behavior, but that is completely the opposite of the behavior, that you can't do and do the behavior at the same time. So these are the three foundations of the habit reversal training. Now the whole treatment package, as I do it, and it might be a little different, have a few different steps with somebody else. First step is destigmatization, which is to get people to not feel so badly about themselves and their behavior. And the next steps here are all parts of the habit reversal training part of the treatment. So increasing awareness and doing behavioral analysis, so just learning what your triggers, hotspots are, all the who, what, when, where, and why questions. Learning relaxation training, a more extended method, and then learning proper breathing to go along with that. And then learning a more brief kind of relaxation, because this one, the longer version takes about 20 minutes, so you need something a little faster than that. Competing response training, which is that muscular exercise you do, which prevents you from pulling at the same time or kicking or biting. And then assembling the three steps of breathing, the brief relaxation, and boy, I don't know what you're doing there. It's pretty active, whatever it is. Stimulus control, which is really very important. I'm going to spend some time on this because I really think this is like the latest and greatest for me. I find I get some of the best results working through this. A weekly review and evaluation of how a person's doing as they come to weekly sessions, or if you do it on your own, you can do your own weekly review. And maintenance and relapse prevention, because as you'll hear me repeat again, this is a chronic problem and it must be treated like a chronic problem. It's not like you get cured. There is no cure, I'm sad to say, but you can recover and you can stay recovered. So, is there a lot to do with this? There is, and as the famous self-help group chain around the country, not everybody's heard of this group. It's called Recovery Incorporated. Has anybody here heard of them? Yeah. They're pretty neat. They're all over the U.S. They're like AA. They've been around for about the same length of time as AA. I always like this little cartoon. If everyone is telling me I'm collectible, why do I see myself as junk? Those little snow globes there. So what is the emotional experience of body-focused repetitive behaviors? Well, I think no big secret that these things involve feelings of depression, shame, secrecy, isolation, loneliness, and feelings of unattractiveness. These are all very common things. I hear these from people every day. We have to deal with them. They can't be ignored. And people think that, that when we talk about behavior therapy, that's all we do. We actually do what's called cognitive and behavioral therapy. And I'll tell you a little bit in a few minutes about cognitive therapy. But behavioral therapy by itself can't get the job done. So we use cognitive methods also, which I'll come back to in just a moment. Some studies that have shown how some emotional responses to hair pulling. This is a study that Dr. Mansueto did about 16 years ago. Of his sample of people, he found 84% showed low self-esteem, 82% had a diminished sense of attractiveness, 80% had feelings of shame and embarrassment, 68% had problems with tension or anxiety, and 66% suffered from depression or mood problems. So as you can see, this is there is serious emotional fallout connected with this stuff. This isn't just picking, pulling, and biting. This really affects the way people feel about themselves and their lives, and this cannot be ignored. And in addition to that, if you look at all the activities that people avoid when they have these problems, these are some very typical ones. Haircuts, which is obviously the most obvious one. Swimming, being outside in the wind, sports, sexual intimacy, going to lighted areas, brightly lit areas, and public activities. This is Ruth Stemberger found this just 6 years ago in a study that she did. So this is very, these are very common activities. So, people's lives are actually limited by this. This is, again, I try to always, I'm trying not to convince all of you, it's like preaching to the converted, but people really are affected negatively by this, and it has to be dealt with. In other words, you can't just deal with the behavior. You have to, I believe in treating the whole person, basically. You can't just say, oh, well, we'll just work on the pulling, we'll ignore all this other stuff. You can't. If you do that at your own risk, and you're going to fail, too. Okay, strategies. I just list these because just to give you an example of how people feel about themselves. When you see the lengths that they go to cover the damage that they do to themselves, and this is not even probably a totally complete. These are things that I typically see among my own patients, these kinds of behaviors, without focusing on any particular one of them. But people do sort of become so focused on this stuff that it seems to some people it's like all they can see about themselves anymore. It's all they can see themselves as, and I think that's a very negative kind of a thing. Or as the person in this cartoon says, she says, sometimes I'm not sure if I'm me or I'm my hair. And I think there's a great deal of truth to that. As I like to tell my patients, a lot of patients sort of view themselves in terms of their behavior. In other words, this is how they judge themselves. This is how that's all their view of themselves is limited to. Like as I tell my patients, they say you're a person who also happens to pull, pick, or buy. You're a person first and foremost, and that's something not to be forgotten. I think a lot of people feel that they're weak, and if they were better, they would be able to do these things. They would be able to control this. There's something that people come up against in their own minds, I think, which I like to call the moral model of psychiatric disorders, which says that people who cannot seem to control their own behavior are clearly weaker than others and lacking in character, and therefore have no one but themselves to blame for the problems they've obviously brought upon themselves as well as their continuation. So some people actually believe that this is so. They feel that they're suffering from a kind of personal weakness, or it represents a personal failing on their part if they can't get control of this. And as I say, I try to convince people that this is a bogus model. This makes no sense. It doesn't apply to the real world. It's sort of an old-fashioned kind of like moralistic view that it's not an illness, that it's a weakness of some kind, and you should never look on it that way. But destigmatization, what we have to do is the first step in any therapy for this. Now, let me just clarify one thing. Not everybody needs to be destigmatized. Some people will come in and say, I feel okay about myself, I like myself, I accept myself, I just don't like this. So I'm not saying that everybody feels these things, but enough people do that it's certainly worth mentioning. Destigmatization, I mean learning to separate yourself as a human being from your behavior. Those saying, it's my behavior, it's not me. Basically, something I do, but it's not my identity. It's not me as a person. And accepting the hair puller, skin picker, or nail biter within yourself. In other words, this is part of you. It's like one time I was on a website for autism. I have a son, a 13-year-old son who's autistic, as a matter of fact. I've learned a lot about these behaviors from him also, from just living with him all these years. But it said on this, they were talking about autism actually, but I thought it applied to other things. The quote on the website was, they said, "It's the wiring, stupid." So I think that's the way you have to see it. It's not a weakness or a failure. It's your wiring, basically. It's just something wrong neurobiologically. That's what it is. So what do we do for this? Well, we were saying behavior therapy is fine for behaviors, but what do we do for the thinking part of this? Well, for that we use something called cognitive therapy, which is not as well known as it ought to be, but it is getting to be better known. It's based upon the theory that many emotional disturbances are caused not by other people's actions or by external situations, but rather by the illogical or extreme ways we view and interpret these things. So it says cognitive therapy attempts to treat disturbed emotions by teaching people how to spot errors in their thinking and how to have emotions that are more moderate and appropriate for whatever situations occur. And this leads to better coping. In other words, people, places, and things don't disturb or upset us. We disturb ourselves about them through the views that we take of these things. So if you want to cope better with things, if you want to have more moderate, controllable emotions, you have to think in more moderate, logical, and sensible ways. So this is what we try to do with cognitive therapy. Now, some of the irrational beliefs, which are what we try to learn to spot and correct in cognitive therapy, these are some very typical things that are seen in not only trichotillomania sufferers actually, but body-focused behaviors in general. One is, and I hear these like every day of the week, If I cannot control my behavior, I am weak and worthless individual. I must make perfect progress. I hear this a lot. And if I can't notice if I have slips or I fail, I am weak and worthless and will never recover. Because I have harmed my own appearance, I must be defective and crazy. Because I have not been able to control my behavior in the past, I will not be able to do so in the future. Because I am worthless and defective, I do not deserve to recover. These are all things, I didn't make these up, these are all things I've gotten from my patients, and many people think this, and this really gets in people's way when they're trying to recover. And the rest of them is more even. As a result of my defective appearance, I will always be undesirable and no one will ever want to be with me. If my friends or loved ones knew about my problem, they would think I was crazy and reject me. And I hate my behavior and cannot help but get upset and depressed whenever I face it. These are all illogical ideas that do not make any sense and that do not hold water, and that can be, they can be proven to be false. And this is what we try to do. And obviously, I can only sort of introduce you to this subject today. But these are the things we try to get people to recognize that they're telling themselves, and to get them to challenge these ideas and say, hey, wait a minute, where's the proof that what I just said to myself is true here? Is it really true that no one will ever want me, or that all my friends will reject me? I mean, when we confront these things and we actually go out and challenge these in real life, these things do not turn out to be so. But people do take these for the truth and they act upon them as if they were so. So, the quote I was going to show you before, which I actually changed the order of here, is a fellow who founded Obsessive Compulsive Anonymous, a guy named Roy C. And he said, what other people think of me is none of my business, which I always really liked a lot. It's one of my favorite little quotes here. What we're trying to go for here is, to get away from this idea of worrying about what other people will think of me, or how they will judge me, or how I judge myself, and move toward a kind of self-acceptance. Actually, I always like this little cartoon. It says, always seek the approval of others. It fills the emptiness inside you. It also makes the emptiness larger, so it can hold more approval. So, I think this is what people go for, which I try to show them that trying to get other people's approval is kind of futile, and to even worry about losing other people's approval because of this disorder is even more futile. But as I said, what we're going for here is acceptance. And what is acceptance? For our particular purposes, we say it's a willingness to acknowledge the problem and say, yes, I really have this. It's something that I have, which is not easy for everybody to come to grips with, and to experience every part of the struggle for recovery. In other words, to do whatever must be done, including negative feelings such as anxiety and frustration, and in spite of the possibility that setbacks and discomfort may result. So we're saying when you're in it, you're in for the whole shebang, basically. You're not only in it for acknowledging, you're in it to do whatever you have to do and be prepared for whatever it takes. And if it's hard work and you're gonna slip, recover, then you have to accept that too. You got to accept the whole package. You can't just accept the parts that you like. Some people think that, well, I'll just work to accept it and that'll be it. I won't have to. I used to think that myself, actually, with regard to my son. And I learned something very important, and I sort of put it together in this slide, which I truly believe this is. Acceptance is not some big race you run to the finish. It's a series of small races you must run every day. And that's the absolute truth. In other words, you don't just get to a point you say, oh, I accept it, and that's it. You have to work on this every day, because every day you've got to face yourself or face the problem in one way or another, and you have to work each day to kind of refresh that and accept it and keep it going. Well, I can't tell you everything in the time format we have here about how to accept yourself and some of the ideas that you need to overcome, but at least I think I can increase your awareness. It's actually a very good little book that I sometimes recommend to people, which almost nobody's ever heard of. There's this little paperback called, by a guy named Paul Howe, who's written a whole series of good little books. These skinny little paperbacks, they just sell for a few bucks. But this is one of the only books anyone's ever written about unconditional self-acceptance, which I really like a lot. You can actually, there's a few websites that have stuff on, some call it USA, or Unconditional Self-Acceptance. But it's a really good little book. If you ever want to take a look at it, I do recommend it. Let's see. Okay, step 2. We did step 1, which is destigmatization. And you have all the steps listed, I think, in your handout, too, if you want to follow them, if you just see the order of things. This is building and strengthening an awareness of the disorder and making a behavioral analysis, like really learning about everything that you do with this and every facet, as you will see. Now, first thing we want to find out in these behaviors is what's your style, basically, of what you do. So first is like, again, with pulling, picking, and binding is automatic type, which is done with little awareness during some other activity, like when you're reading a book or watching TV, talking on the phone, on the computer. These are the most common things, driving the car. This may account for up to 75% of hair pulling alone, okay? Second is deliberate or focused behavior, which is preceded by an urge and is done in place of any other activity. So in other words, people usually stop whatever they're doing in order to pull, pick, or bite at this point. This is maybe more compulsive with perfectionistic and ritualistic features. Sometimes it has to be done the same way or in a certain order or certain kind of steps that have to be performed in more deliberate kind of behaviors. And then the third is as a combination of both, done at various times and in different situations. I would say that most people probably, this does account for a lot of it, but I say most people probably do a combination of both automatic and focused behaviors with this. So some more than others, but on the average, I'd say most people do that. So if we're gonna do a behavioral analysis or understand the behaviors, we first have to figure out like what's our basic approach to this. As I like to tell people, I say you cannot change behavior, you cannot anticipate or identify. So in line with what Dr. Azrin came up with years ago, record keeping is very important for this stuff. I have patients keep records on these kind of sheets, and in fact I brought some with me to hand out here. Yeah, there's a couple of different types. So let me sort of take one. I think what we do is whenever people have an episode, these are the ones I use for hair pulling. I have other ones for skin picking and nail biting, so people won't feel left out. But people record the time. We call these, every incident where hair pulling, skin picking, or nail biting takes place, we call it an episode. Okay, so we have people record the time of the episode, time of day it occurred, duration, how long did you spend doing it, how many seconds or minutes, the number pulled in the case of hairs, approximately how many hairs you think you pulled, the strength of the urge, if there was an identifiable urge from 0 to 100, the location, where were you when you did it? Were you at your desk at work? Were you when you're... I always tell people, if you're going to say, if it happened at your home, don't just say in my home, tell me what room you were in or location. Activity, what activity were you engaged in when you either were doing it during that or then you stopped to do it? Implements, did you use any implements? Some people use tweezers or other gadgets or little things to pull, pick, or bite. So I like to know what implements they use and any feelings at the time, any physical sensations that preceded it, or emotions basically. The emotions that I most often see are boredom, anger, anxiety, things like that are the kind of things that turn up. And then here we give people a little chance to record behavioral observations. So anything else that a person thinks is relevant that they observed at the time, they write down. And the purpose of filling out these sheets is not just for the person, it's also to give me information. I say, you're not just doing it for you, you're doing it for me, because it's my window into your problems. So I can't follow you around all day and see what you do. This is how I have an idea of what's going on with you, basically. This is the one I use for skin picking and nail biting, but virtually identical to the other one. Now, in addition to keeping these records, I also have people keep graphs of their episode graphs of their behaviors. And we put a red line. I actually do it on graph paper and actually give it to them to take home. But they keep records of how many episodes they had on a given day. And we put a red line across at 1. So we tell them the target is, it's almost like biofeedback, so you got to keep it below the red line is our goal. But it actually really helps people because you can sort of get a visual record of your progress. It doesn't record everything, obviously, but at least you can see whether the number of episodes are decreasing or not. And I find this to be very helpful. I used to only do this with children because they needed something that they could really see that would tell them how they were doing. But I started doing it with adults because I found that it helped them also. So now I do it with everybody. So people have to every day fill out their graph and a record sheet if something happened. Okay, what do we seek to learn from keeping this information? The locations where it's most likely to occur, the times of day you're likely to be in locations where the behavior is probable, the activities, physical positions, or situations that make the BFRB more likely. In other words, some people, if they sit on the right-hand side of their couch and put their hand on the arm and put their head in their hand, you're going to start pulling, okay? So this is what we want to find out. What are your triggers? What are your hot spots? Where is this stuff most likely to occur? And where can we anticipate it? Because once we know in advance, once we can predict where it's going to happen, we can take some kind of action, which I'm going to show you later on. There are things we can do to prevent these things or to redirect them or to head them off some way once we know. But we've got to have the information first. Without that, we're flying blind. We don't know what's going on. And finally, the moods or physical sensations, which seems to be most connected with the body-focused repetitive behavior. Again, if you know that when you're bored or when you're angry or anxious or stressed or whatever, you're more likely to do these things, this is going to help you to get the jump on this. You're going to know where it's most likely to happen. So, finally, what we're trying to do here is we're trying to identify chains of behaviors. In other words, this is a typical chain of behavior. We call them, each one of these things is a link in that chain. So coming home from a hard day, walking into the family room, sitting in your favorite spot, turning on your television, leaning with your head resting in your hands, as I was just describing, running your fingers across your scalp, feeling the different hair, tugging on the hair, and then pulling the hair out. This is a chain of behaviors. And obviously, we know in behaviorism that the earlier on you can snip this chain, the less likely you're going to get to this spot here at the end. So we try to identify these. We know, for instance, that maybe coming home from, if you've had a hard day, maybe you don't walk into the family room, or as you'll see, maybe you don't sit in your favorite car, or maybe you start to modify these things. So we snip this chain, we cut this chain of events. Okay, and finally, the advantages of understanding behavioral chains. One is you become better able to predict when and where episodes will take place. And secondly, you'll be better able to make changes in your routines or your environment in order to break up the chains, making episodes less likely. Okay, so the next, we talked about now just gathering information about this and learning about it, and learning, sort of picking up where triggers are and recording your own behavior and just sort of being able to anticipate what you do. So the next step, step number 3, is self-relaxation training. And this is the full-length method. This method takes about 20 minutes to learn, basically. I usually give people a tape, although I'm about to convert it to a CD, and I may even make them available through TLC. I used to do tapes through them, but not that many people listen to tapes anymore. But what a lot of this has to do with is, remember we talked about those two halves of your nervous system, the sympathetic and the parasympathetic. It's getting that parasympathetic nervous system to kick in and just sort of calm you down to center you. There's sort of people who pull to reduce stimulation or at least that part of the problem that people have. This is something that can be very helpful. Does it work for everybody? No. Does my particular tape work for everybody? No. You have to find out what works best for you, essentially. But it is one way of doing it. There's a concept you hear a lot of these days. It's called mindfulness. Have many people here heard of this? And basically people always wonder what that is. Well, actually this woman she's a Buddhist nun who writes some really terrific books, by the way. If you're ever interested in seeing her books. She wrote one called The Wisdom of No Escape, and there's another book called When Things Fall Apart, which is, I think, one of my favorite ones. Basically, so she lectures too. She's a really interesting person. I think you can get videotapes of her. But anyway, she says mindfulness is being right where you are, and that's what it is. In other words, it's for our purposes, for this, it's sort of knowing where you are and what you're about at all times, to sort of just be aware of yourself. This is especially I find this an especially important concept for people who do that kind of automatic pulling, picking, and biting, that's sort of out of their own awareness. It is very important that they do this, because a lot of people come and say, yeah, I do it, but I don't really know what I do or when I do it. And actually, many people with these problems in general don't know as much about their own behavior as they think they do. When they start recording and keeping this information and finding out what they do, they're usually very surprised and shocked. Some people will say, I had no idea I did it that much, or that I did it in these particular places, or at these times, or on these days. So it's very important that you learn about these things. But being where you are means being in the moment, essentially. It's just, if I'm sitting here on the sofa right now, where are my hands? How am I feeling? Is this a trigger for me? Is this like a challenging situation? Is there something I ought to be doing right now? And it's just being aware of all those things. So, and again, that could be. I know there are other people lecturing on this. It could be a whole lecture in itself. Along with learning to relax yourself, as this relaxation exercise does, and with the tape as I do it anyway. In my book, as a matter of fact, I put the script of the tape in there. So if somebody wanted to record their own tape using my method, they could do it. Or if they had a friend with a nice voice that sounded relaxing, they could get them to record it for them. The next step is diaphragmatic breathing training. Learning to relax yourself is also about learning to breathe. And breathing itself has a lot to do with mindfulness and sort of being in the moment. Breathing is a way that you sort of center yourself. People get kind of scattered. They get, they're busy doing what nowadays is called multitasking. you know, or as my mother used to say, trying to do 3 things at the same time. But it's a lot about centering yourself. And when you focus and concentrate on your breathing, for some people, it's almost the way they focus and concentrate on their pulling, picking, or biting. It actually centers you and calms you. It offers an alternative, and breathing is probably one of the keys to relaxation. And if you study meditation, you see breathing is also central to that. I sometimes recommend that my patients go for yoga training because it helps them stretch physical tension out of their bodies. It teaches them to breathe, and they also learn meditation and relaxation. So it's a really neat package. In fact, almost all my panic patients go for yoga because it's such a great adjunct to panic attack treatment. It's wonderful. Even, you know, real like macho guys who don't believe in that stuff, when I get them going, they really like it. So I find it's very helpful. So people learn the longer relaxation, then they learn breathing, and they do that together with the relaxation at this point. And then when they master that, we go on to a briefer kind of relaxation training, which takes between about 1.5 and 2 minutes to do. It's a much faster way to relax yourself because you can't always do a 20-minute relaxation exercise if you're trying to fight off pulling, or you're at work, or you're someplace else, and you can't sit down with a tape and do all that, which is obviously not very realistic to ask people to do. So we try to come up with something portable where you don't need a tape or a DVD or a CD, something you can memorize and carry around in your head and use it wherever you are. So that's also actually in my book along with that. But there's many ways of doing brief relaxation. I have people who do self-hypnosis, all kinds of things. It's all very similar. Most of these things contain a lot of the same elements, whatever you call them. So okay, so that's step 5 on our list. Step 6 is what we said before was a competing response training. And I don't use this as a sign of aggression, but that's actually what we do as a competing response. Now, just to show you what it is before you get a little about competing responses, what I usually have people do is clench their fists, hold them at about belt buckle level, and you tense your forearms and clench your fists at the same time, and they hold it like that. How long do you do it for? Well, I used to have people do it for 3 minutes, but then Dr. Doug Woods did a study where he had people do it for, it was 3 minutes, 1 minute, and 10 seconds. The people in the 3-minute group worked okay for when they didn't have a reversal. He's one of the big habit reversal researchers, actually, Dr. Woods. And then the people who did it for 1 minute did okay also. They did as well as the 3-minute people. 10-second people didn't work for it at all. So instead of 3 minutes, I said, well, if 1 minute will work as well as 3, we'll cut it down. So now I only have people do this for 1 minute, basically. So what does a competing response have to be? Now, whatever the habit is, I don't care what you're trying to deal with here, it says it should be incompatible with the habit. It should be able to be maintained for a minute or more without appearing unusual to others, but you can usually kind of just sit with your hands. I'll tell people sometimes to just sit and grip a pen or the arms of a chair or something like that if you're around other people and you can't, do that. It should not interfere with normal activities. Well, it might interrupt for a minute or so, but it wouldn't be a major interference. Like no more than pulling, kicking, or biting would be. And it should heighten your awareness that the habit is not occurring. This comes from Dr. Azrin and Nunn, actually, in a paper they published, and it's still true. So this is the last of the skills that we teach in HRT, and then the next step, step 7, is where we assemble the steps. So it's like, it's got making a wall out of bricks, basically. We put together the various steps and we assemble our habit reversal training. And what are the steps? So we tell people when you get and I think I put this in your packet, what to do when you get the urge to pull, pick, or bite. It says, number 1, it says begin deep breathing, take several deep breaths, okay? Do brief relaxation and breathing together. That should take about 1.5 minutes altogether. Do competing muscle for 1 minute. Okay, and then it says if the urge persists, repeat steps 1 through 3, and then you can repeat as necessary if you need it. HRT must be performed whether before, during, or after the body-focused behavior. This is very important. In other words, first choice, of course, is to do it before and don't do the behavior that we're trying to avoid. That would be number 1 choice. Number 2 is if you can interrupt it and break it up and do your habit reversal. That's almost as good. We like that too. Thirdly, if you missed the boat and you still did your behavior, you know what? You got to do your habit reversal anyway because you need the practice. And we tell people, you've done this thing like hundreds and hundreds of times. So, you have to do your habit reversal training until that becomes almost as automatic as the behavior you're trying to overcome. So this is why we try to do this. Now, once we do our habit reversal once we switch into doing the full, we've assembled all these steps here as part of the treatment, we give you a different, I think I gave these out also. What we do here is we no longer ask people how many hairs you pulled or anything like that. But what we do ask people is when you had the chance, did you use your habit reversal training? Did it work? And did you do it before, during, or after? And it's very easy. So this is either a Y or an N for yes or no, Y or an N for yes or no, and it was B, D, or A for before. So I try to make these sheets very easy to fill out so people can't say, oh, it's too hard. I couldn't get around to it, it was too difficult. So this is what we do. So we just record a little bit differently, but we still keep recording throughout. You want to always be aware of this and know what you're doing. So okay, so that's the habit reversal part of this program. Then we move over to something that I really, really like, which is stimulus control and motivation building. Okay, stimulus control, again, is how, it's like it says here, who, what, when, where, why, what. We try to account for all these things, all these triggers, and all these inputs into the problem. Before, with habit reversal, we were just dealing with the physical behavior itself. Now we're going to deal with all the things surrounding that behavior and that affect it and that are inputs to it and that can influence it in some way and cause the behavior to happen. So, okay, so let's talk about what is stimulus control. It's actually a very old behavioral treatment, very well known. It says a behavioral treatment that seeks to help sufferers first identify and then eliminate, avoid, or change the particular activities, environmental factors, states, or circumstances that trigger undesirable behaviors. So it's basically anything that feeds into the behavior or triggers it, we want to be able to identify and then modify in some way or eliminate it. It says the goal is to consciously control these triggers that lead to pulling and the other behaviors, of course, and to create new learned connections between the urges and new non-destructive behaviors. So we're trying to forge new connections. So in other words, where you were sitting on your sofa, leaning over, pulling your hair before, now maybe we're going to sit in a different spot. We're going to sit in a different posture. Maybe we're going to have something for our hands to do. We're going to come at this thing from a number of different directions. So now, what are the parts of stimulus control? There's a number of components here. One is we look for stimulation replacement. So there's other ways to get stimulation that are not self-destructive. Stimulation reducers. In other words, for when you're overstimulated, ways that you can calm yourself. Relaxation is one of them, but there's a whole bunch of other things that you can do to reduce your levels of stimulation. Again, we're trying to maintain this balancing act here. We're trying to stay within this zone, but at the same time, we want to do things that will not lead to the habit itself again. Habit blockers, things that just, like our habit reversal with our fist clenching, that's just one way you could block yourself from doing the habit. There's many others. Changes in your environment and routines, very important. Reminders and attention getters, again, I'm a big believer in that. All my patients use lots of Post-it notes. I'm real big on Post-it notes because you take them down when people come to visit you and they can put them back when they leave. And belief enhancements, in other words, things that enhance your belief that you can accomplish this, that you can do it, that help your motivation, basically.